Welcome to the Cross-Training Workforce for Integrated Care and the New Drug Medi-Cal Waiver System of Care webinar, presented by the California Institute for Behavioral Health Solutions and the California Department of Healthcare Services. I now turn it over to Dr. Will Rat-Merskel.
Hi, good morning, everyone. This is a continuation of a series of webinars and some regional trainings that we've been doing this winter and spring, related to helping prepare folks for the new drug Medi-Cal waiver, and also just thinking about ways of improving the service system, the delivery of the services that we provide, both in SUD, but also thinking in terms of integration with mental health and physical health. And so we're really pleased to have Dr. Richard Rawson with us today. He's a co-director of UCLA Integrated Substance Abuse Programs, and he's a professor in residence at the UCLA Department of Psychiatry. He's been a member of the department there for over 20 years, and he oversees clinical trials on pharmacological and psychosocial addiction treatment. He is a principal investigator in several federal grants, and he also has led research and training projects internationally, the United Nations, the World Health Organization, as well as nationally, the U.S. State Department, and trying to help export science-based knowledge to many parts of the world. He's published 3 books, 35 chapters, and over 200 peer-reviewed articles, and has conducted over 1,000 workshops, paper presentations, and training sessions. So we are very pleased to have Dr. Rawson with us today to present to us on behavioral health integration in the organized system of SUD care. Dr. Rawson.
Thank you very much, Will. Appreciate the introduction. And I will hopefully can provide some useful information for folks today. Yes, I've been doing work in the addiction field, started in 1974 in Oxnard, where we were doing some of the first work with treating heroin users using naltrexone and behavior therapy. So workforce has been an issue that has been something I've been very interested in ever since then, because as we were starting in the early 70s, we were inventing the workforce and helping to define what skills they needed. It's a very topical issue. In this month's Atlantic magazine that's currently out, there's a big article on substance use disorder services. It's a very critical article about the nature of the services, and one of the pieces of criticism that is highlighted in the article is the workforce, that the people who provide substance use disorder services don't have the same level of training and expertise that it happens in other areas of medicine. Now that's an arguable issue, and this particular article takes a very extreme position, which I don't agree with, but it just shows this issue comes up all the time. In many of the projects we're doing in the state of California and around the country on integrating substance use services into primary care, one of the things we hear is, well, we're going to do behavioral health integration into this FQHC or into this primary care setting, but really substance use services aren't ready for integration yet, so we're going to focus on depression, anxiety, and other mental health areas because the workforce in the substance use side really isn't ready to be working in primary care for a variety of reasons. So it's an issue that's coming up a lot. It's an issue that will continue to come up a lot, and whether those things are true or not, I think it's important for the workforce to be proactive and to eliminate some of those potential concerns that are out there right now. So my remarks today are going to be on some of what people at SAMHSA, people in the National Quality Forum, and a variety of other groups are anticipating to be some of the directions that the workforce will be heading in and some of the skills that will be important as we move forward, not just for behavioral health integration, but also as the state of California reorganizes its system of care via the drug Medi-Cal waiver that is currently moving forward. And I'll talk about all these things as we go through and what the implications are for knowledge and skills for the California workforce. Now, just in advance, I'm not going to talk about physician workforce or psychiatrist workforce. I'm talking primarily about the people who deliver psychosocial services, counselors, psychologists, social workers, and others who deliver the behavioral treatments and who work as part of teams with multidisciplinary teams as part of treatment systems and treatment organizations. Okay, so what I'll start with is the current substance use disorder workforce. Then I'll talk a bit about how the needs of behavioral health integration impacts the substance use disorder workforce, and then how the changes that will be brought about by the drug Medi-Cal waiver are going to change the roles and skills needed by the workforce in specialty care substance use disorder organizations. So a little bit about the current substance use disorder workforce. Currently in the state of California, approximately 35,000 individuals are registered as alcohol, drug abuse counselors. This 35,000 number also includes social workers, nurses, psychologists, and in some cases psychiatrists. If we look at what the role of the state substance use disorder workforce is in a recent report, a 2012 report by the Health Workforce Development Council, which is a committee in the state of California that looks at all workforces, their term was that the state substance use workforce is undefined, lacks clear parameters, cuts across multiple licensed, certified, and unclassified professions. So their criticism was, we don't really have a very tight set of standards for the definition of the workforce that provides counseling and psychosocial services in the state of California. And that same criticism has been heard in a number of other reports, one which we did a couple of years ago, and has been an ongoing issue in the state of California that we have not fully defined what it is that people in the workforce need to know and what skills they need and exactly what their roles are within the substance use disorder service system. So California is certainly going to have a need to expand its workforce. The state of California has fewer substance use disorders counselors per capita than any other state in the country. Has very few board-certified addiction psychiatrists to provide our addiction expertise at the level of psychiatry. And we know that this demand is clearly going to grow in California for a variety of issues, including AB 109, which is moving people out of the criminal justice system into the treatment system, hopefully, and of course the implementation of the Affordable Care Act, and I should also mention because of the drug Medi-Cal waiver. All of those things are going to increase the demand for a skilled workforce who can provide treatment in both substance use disorder specialty care as well as in primary care and in mental health care as part of teams that work in those settings. So this is the depiction of how our workforce currently operates. We have out in large medical settings, we have medical teams, we have in some very few cases some behavioral health workers in those medical care systems. Mostly the behavioral health workers are providing mental health services, addressing things like depression and anxiety and other mental health disorders, but even that is relatively minimal at this point. For the most part, in the medical care system, we have doctors, nurses, medical practitioners. In the mental health system, we have the whole array of mental health professionals, psychiatrists, social workers, licensed clinical psychologists, marriage and family therapists, and a professional workforce that provides the mental health services for within the Department of Mental Health or the former Department of Mental Health's service system. And then we have the substance use disorder system where I've lived for the last 40 years and have provided care, both counseling services, medication services, and where most of our treatment programs exist, and where there will still be a need for a robust workforce to provide evidence-based services as we move forward. So we still have these three silos that are currently operating. And within our silo of substance use disorder services, there are siloettes. There are little sub-silos within each of those, within each of the major substance use disorder. We have people who work in NTPs, methadone clinics. They know how to work with patients on methadone, and they provide support service and a behavioral health service that addresses the needs of those patients. We have people who work in residential settings, people who work in outpatient clinics, people who work in withdrawal treatment or detox centers. And then we have, in a few cases, recovery support centers where people are working in a more informal environment where they're providing recovery support for people who have maybe been in treatment and who are trying to sustain their recovery. So within each of these settings, we often have a unique group of people who do a unique set of tasks and skills, and in many cases there's not much understanding of what goes on in the other siloettes. I mean, if you ask somebody who works in a residential treatment program what the daily tasks are of a counselor in a methadone clinic, they probably wouldn't have much understanding of that, and ditto all the way around the big silo. Also, you have within these different silos different treatment philosophies. You have the social model and abstinence-based models in many of the traditional residential programs in the state of California and some of the outpatient services. In the methadone treatment programs, you have much more of a medication-assisted approach and a harm reduction strategy. So there's big walls between, even within the silo of substance use services, and the workforce reflects that. Typically, the workforce knows what goes on in its silo, but it really doesn't understand, and in many cases, it doesn't appreciate what goes on in the other siloettes. So what we're thinking is likely going to be kind of a big paradigm shift is that we'll probably see a set of specialization for people working either in the behavioral health world, where they're working in primary care or mental health care, and they're providing substance use disorder expertise as part of teams in these integrated health entities. We also will see people who continue to work in the specialty care system, in the treatment programs that deliver treatment for people with addictions. And so there will be both of these that occur, and it doesn't necessarily mean people can't work in both, but the skills that will be needed will be somewhat different in the two entities. So let's talk first about the skills that will be needed to work within the behavioral health world. And this is a new development. We have some federally qualified health centers in the state of California where they have quite robust programs of behavioral health. As I said, most of it is around mental health services, screening for depression, screening for anxiety, screening for PTSD and other mental health issues. But increasingly, there are some projects that are integrating substance use disorder services. And it's one of the goals of the Affordable Care Act is to see this integration occur to a much greater degree. So there will be pressure on all big health systems to promote this integration and to figure out how to do it and how to pay for it. Right now there's some obstacles, but it's something that is part of the next 3 to 5 years to be developed.
So Rick?
Yes.
I don't know if this is a good time, but there have been some comments already.
Sure.
Should I share with you? Okay. One comment is that the medical field did not treat drug and alcohol problems as a health problem, clueless as to how to treat patients with those problems, and did not integrate with drug and alcohol treatment programs. This is a comment.
Well, yeah. I mean, if I understood the comment, if you go back in history a bit, in the early 70s, just when I was getting started, the substance use disorder and mental health services were split, in part because as one big entity, substance use disorders were being ignored, and substance use disorders in primary care are still, for the most part, ignored. And part of the reason they're not addressed in primary care right now is that most medical professionals working in the primary health system don't have the knowledge and skills. They don't screen because they don't know what to do if they find substance use disorders. And many of them are extremely happy that this integration is occurring because they know they have patients who need substance use services, but they don't know how to do it. So we're getting a lot of enthusiastic support from the medical side about getting help with substance use disorders. Okay,
great. And now we had someone else who was asking, when you're talking about workforce, what about peer counselors? Where are we in this conversation?
Peer counselors are very definitely part of the conversation and part of the team that will be used in both settings, both integrated health settings as well as in the specialty care system. The roles of peer counselors and how they will function and what their role will be is one of the tasks we have to define, because one of the areas we've been criticized for by big medicine is that it's not clear in our workforce who can be expected to do what, and that I think that we've done a pretty bad job in kind of defining what tasks and responsibilities and scope of work should be done by peer counselors, what should be done by licensed therapists, how should the team be constructed so that everybody's doing the job that they're qualified and trained to do. But clearly, peer counselors will be a big part of the workforce going forward, just hopefully with somewhat clearer defined roles and responsibilities.
Okay, and then I have another one that I don't know if you think it fits now or might fit in what you might say later. Here's someone who says they're an office manager for an NTP clinic, and I'm aware NTP is included in the waiver. I would like to hear some info on how this will all work and affect us. So
okay, let me make sure I come back to that when we discuss the waiver and its impact.
Okay, perfect. Go ahead.
Okay. All right, the Affordable Care Act, I suspect many of you have been to webinars and been to lectures on the Affordable Care Act. I won't go into detail on this other than to say it has had a big impact on expanding the number of people who are eligible for Medicaid, and in our specific case, drug Medi-Cal in California. It's particularly expanded the access to Medi-Cal for males, because until the Affordable Care Act, it was very difficult for males to get drug Medi-Cal. It also has made available insurance to people who previously did not have insurance, and so with all of these people now having the ability to receive treatment and health care through these insurance plans, we're likely to see, and already are seeing, a lot more people entering treatment. I haven't seen the data recently, but I do know I looked at it 3 to 6 months ago, or about 3 months ago, I guess, and there was already clear evidence in methadone programs of an increased census driven by the fact that more people have drug Medi-Cal, and drug Medi-Cal covers methadone treatment. In the other levels of care, there are more complicated issues because we're still figuring out exactly the parameters for the new benefit that drug Medi-Cal will have in the other areas. And all of these plans will have substance use disorder treatment as part of the Affordable Care Act, and we expect that within the primary care settings, we're going to see increased attention given to substance use disorders. In the state of California, it's now a requirement in federally qualified health centers and other health centers for people to be screened for alcohol disorders. We argued for including both alcohol and drugs, but at present the data are only supportive of alcohol. But there is more screening done. Tom Fries in our training group and others have been doing a lot of training around the state of California with primary care organizations, teaching them to do screening, brief intervention, and referral to treatment. That results in increased awareness of substance use disorders, and when they identify patients who meet dependence criteria, there will be increasing pressure for them to refer patients to the specialty care setting, and that's where our specialty care setting will see an impact. And in part, this is, as I mentioned, the future of the way the health system will hopefully work is that primary care will integrate behavioral health with substance use disorder and mental health care being delivered out of the primary care settings. And the number of models for how to do this and the different ways this is likely to be done are right now almost infinite. There's a lot of different pilots going on in counties all over the state looking at how to best do this. There's some innovative programs where Suboxone is being delivered out of primary care to try to bring the treatment closer to the patients. There are some projects with brief treatments being delivered out of primary care, and treatments that address both mental health and substance use disorder services out of primary care. But these are mostly still all at the pilot stage. There are organizations like Kaiser who have done some of this, done much of this work. So there are systems that already are working on integrated behavioral health, but it is a new area and it's one that's currently being defined. Here's a set of some of the issues I think it's important to be aware of. If you're planning to develop a career to work in primary care as a behavioral health person, I think it's important to be aware of some of the differences in your job and what you'll be doing and how you'll be doing it. If you think about the environment, in substance use disorder services, I worked in them for many years. Generally, we see people for long individual and group sessions, hour-long, hour-and-a-half long, sometimes 3-hour blocks of treatment. And it's something where we see people over a long period of time, and there's a big intensity to that. In integrated behavioral health settings, that's not how they work. They work, primary care is a very fast-paced environment. And if anybody's interested in doing this, I certainly would recommend you go and visit a federally qualified health center or a primary care center to get a sense of what the environment is like. It's very fast, lots of people going in and out, lots of short sessions, and it's a very brisk environment. The treatment population in our substance use disorder treatment programs are people with primarily substance dependence. Many of them people with long chronic histories of substance dependence. In the integrated behavioral health setting, primary care, we're going to see people with mental health and substance use disorders at varying levels of severity. There's going to be much greater variability in the patient population. And so the treatments that we've developed to be used with people who have severe dependency in our specialty care may not fit in primary care. Well, actually, they won't fit in primary care, and other strategies will need to be developed. In substance use disorder treatment, historically, our focus has been on giving people knowledge and skills to reduce their drug and alcohol use, become abstinent, and that's really been our focus. In the integrated behavioral health, it's a much broader focus. It's not, you can't go in and be solely the substance use person. The doctors and nurses want someone that can help them with a range of issues, not just substance use services, so there will need to be a broader set of skills. Within the substance use disorder programs, and this is changing, but historically it's often been people have caseloads, they're their patients, they are the primary person delivering service, and oftentimes they're doing it in isolation. They have their own caseload and they work with their own caseload. In behavioral health setting, you're going to be part of a team, and this is going to be a big change. The doctors, nurses, and other members of the health team are going to have input. They see those patients as their patients too, and the person doing substance use and behavioral health will need to operate within that context. And finally, the payment system will be different. We've always been paid in the past by the block grant, very simple mechanism. Now there's going to be all kinds of other structures. So here's a few, just to go over these in a little bit more depth. In the primary care setting, in the integrated care setting, things will go fast. Assessments will need to be done quickly and accurately, and so you'll need to develop a set of tools for doing assessments that are much more time efficient and can be done with people in shorter periods of time, maybe over time, several sessions. The services need to be in a target, time-efficient manner where you're addressing the particular problem that both the medical professional has identified and that you've identified and the patient's willing to talk about, and it has to be done quickly and efficiently. And your communication with your team members is critical. One of the things that has been the biggest problem in some of the behavioral health integration with substance use professionals has been their lack of communication to the rest of the team. They tend to get a patient, it becomes their patient, and they're going to do whatever it is they're going to do, and they fail to communicate back to the other team members of the primary care team, and that can be problematic. Of the skills that need to be developed, these settings where people, in these primary care settings, for the most part, people have not come into these settings for their substance use disorders. When somebody walks into a drug treatment program, they're there to deal with their substance use. When they walk into a primary care setting, they may be there to deal with the fact that they have the flu, or that they want to get a medical test, or that they have some kind of back problem. They're not there to deal with their substance use disorder. So the way in which behavioral health has to integrate with them and interface with them requires some real skills, some motivational interviewing skills, some skills that will allow you to talk with people and get to talking about their substance use disorders so that they don't feel ambushed, that they came in to talk about the flu. How come all of a sudden you're talking about their alcohol use? And it's a set of skills that does require a pretty good level of sophistication to be able to engage people to talk about their alcohol use when that's not why they came in the first place. And so it does take the development of some skills, and then to effectively communicate the information to team members. Often many of the team members, the doctors and nurses, don't know anything about substance use disorders. They don't understand what you might be recommending that is done, and so you're in a teaching role with these colleagues who may outrank you in the medical world, the doctors and psychologists, but you may be the person with the right expertise. So figuring out how to communicate and be team members is an important set of skills. Mentioned that the screening and assessments will be important. The idea that you're going to do an ASI on people in primary care isn't going to happen. But you'll need to do some kind of screening, which there are a variety of screeners that we've developed and have been validated, and then some kind of brief assessment that gives you a place to start in addressing the substance use disorder. And hopefully this would be something you can address together with their other behavioral disorders. When you're working in a primary care setting, for the most part, the doctors and nurses don't want to hear that you'll deal with the alcohol use and somebody else will deal with the depression. They want to have one person they can go to deal with behavioral health. And so it's having a broader range of skills will be important in these behavioral health integration activities. And the interventions will need to be targeted. These won't be doing global assessment of a person's substance use disorder history and how it affects all aspects of their lives. These will be efficient, clinically targeted interventions, generally in a short number of sessions, maybe 3 to 5, and generally in sessions that are short, maybe 15, maybe 30 minutes, but typically 15 minutes. Within the medical setting, it's going to be important to have an appreciation for a harm reduction approach. That is that the whole, in our specialty care system, much of our specialty care system is about engaging people in long-term chronic treatment, helping them get into recovery. Here, it's much more about helping them deal with an immediate problem of drinking too much or taking drugs and giving them some recommended solutions. Here you have to remember you're in it for the long haul, that if you try some of these brief interventions that you're working with the patient to help them deal with on a short-term basis, if they don't work, you will have developed a bond with the patient and credibility to be able to refer them over to specialty care where they can get the treatment they need. But initially, it needs to be these targeted approaches. There's been some developed by people around the country. Adam Brooks in the University of Treatment Research Institute in Pennsylvania has a really nice set of materials for working in primary care. And I think these treatments really orient people toward more rapid behavioral change. Now, clearly, for somebody who has a 20-year heroin addiction problem, this is not going to be an appropriate set of activities. But for people who have lower-level severity disorders, these can be extremely useful. And that's one of the changes in primary care that is a change in perspective, that we're helping them deal with their existing problem right here, right now, and for many of them, it'll actually be valuable. For those with more severe disorders, over time, we will move them into more traditional substance use care. Obviously, it goes without saying that in these settings there will need to be the ability to understand the culture, communicate effectively within the culture, communicate effectively with the right language. The care planning that would be done in these settings, here again, you don't, as the substance use professional, you don't go and sit in your office and write a treatment plan without involving the other members of the team. This is a part of an overall team approach for treating the whole person, and this all has to be coordinated with the doctors and the nurses. How that's done is different in different settings. In some places there are team meetings, there are weekly case conferences where these kinds of things can be discussed, but it is essential for this to work for the doctor who's treating the patient's diabetes to know what you're doing for the patient and their alcohol disorder and how it's working, and so they can effectively take care of their diabetes condition, etc. And really being a member of a team is an important thing, and I think that over the years with many of the people I've worked with and many of the settings, they've been great team members, and they've worked naturally as team members. Others, on the other hand, have been much more, I want to work alone, I want to have my caseload, and I don't want anybody to bother me with what it is I'm going to do. I'm the expert, and I'm going to treat my patients. That attitude won't work in a primary care setting. So it's one where you really need to like working as part of a team, and if you don't, this would not be a good setting for you to work in. And over time, what you will see happen is that the substance use professional, the behavioral health professional, will start to become used more as a in consultation and liaison manner. That is, the doctor will call you in, or the nurse practitioner will call you in to advise them and the patient on what are the next steps, what should we do, what should we be planning to do. As you develop credibility within that setting, and the rest of the team starts to recognize your value to them, you'll see you'll be called upon to be involved in many more aspects of their health care. And that's a good thing. I think it's good for patient care, it's good for the development of the behavioral health field, and I think it will result in behavioral health really living up to its promise of reducing overall health care costs by addressing these behavioral problems, which are in many ways the driver of many of the chronic illnesses that are drive up healthcare costs. So we, over time, your expertise gets recognized, and you start to be called upon in a consultation liaison manner. So that's covering the issues of the what will happen in integrated care. Let me talk now about what's going to happen in specialty care as we understand it with the plan currently underway for the waiver that is being has been developed and is under review right now, that will change how drug Medi-Cal operates in the substance use world. This quote, I think, is helpful to keep in mind, that in times of change, the learners inherit the earth, while those who are the learned find themselves beautifully equipped to deal with a world that no longer exists. This is changing. It's clearly changing, and what's going to be expected of the workforce is going to be different. And that's being driven in part because of both the Affordable Care Act and parity. Again, to reiterate, we'll see an increase in utilization. Estimates say it'll go up by 36%. In some geographic locations, it's estimated it'll go up by 50%, the demand for treatment. And that the California substance use disorder workforce will need to be expanded by close to 3,000 FTEs at least. And that within the subspecialty care, the standards and requirements that are going to be required, because this is now being paid by medical insurance, not by the block grant for the most part, you'll see standards and requirements and regulations that are going to be more stringent and will require the substance use services field to operate the same way we see people operate in hospitals and other medical settings, mental health settings. And there will need to be more, the documentation and codification of the services will need to be more formalized as per insurance requirements. Within California, within the Medicaid system, the drug Medi-Cal waiver is going to dramatically change the substance use service system in a good way. It's going to expand the number of people who can get care, and it's going to expand the types of care they can receive and the amount of care that they can receive. Let me back up. So within what is being called in SEC by DHCS an organized system of substance use disorder care, and that's an important term, an organized system of care. You need to sort of, if you, again, you take a historical perspective, substance use disorder services in California, starting in the early 70s, did not develop as an organized system of care. They developed as a bunch of treatment programs that were driven by some new funding, a new crisis, the HIV epidemic, the methamphetamine problem, Prop 36. Every once in a while, a little spasm of funding would come along, and programs would open, and then programs would close. But there was never an overall plan for a system of care, at least in most counties in California. But now we're going to, the state is going to require, drug Medi-Cal is going to require, each county have a plan to develop an organized system of care. That will include the listed services: residential treatment, physician consultation, outpatient treatment, case management, medication-assisted treatment, and withdrawal management. And these services will be structured into a continuum of care as modeled using the ACM criteria, which you may have already heard about. So it's no longer just a bunch of programs out there that do what they do. If you think that we had all these little siloettes of services that delivered what they did, and they didn't really care what went on in the other siloette, that's going to need to change to create a true continuum of care where we have interlocking services where people who go through withdrawal management are expected and anticipated and planned to go into another level of care. It won't necessarily be residential care. It could be go from withdrawal into outpatient or intensive outpatient, or but there will need to be a model that uses this chronic care model of starting people where they need to start, whatever level the ACM criteria place them, and then they step down into other levels of care, or if they're not doing well, they step up to a more intensive level of care. And this will be driven as part of this overall organized system of care. So if you think about how that affects the operation of things, when we operated as silos up until now, and probably for a while now, but hopefully it'll change, programs operate as individual programs. You don't really think about what the other programs, 3 miles down the street do, or how they do it, or what they do, or if your patients could benefit from their services, because you have your services and you deliver your services. When it's a continuum, there needs to be a lot more interaction between programs and levels of care. Now, some programs have all levels of care, and that's great, but I suspect even the biggest programs don't have geographic coverage where they can, if they have somebody who comes in for withdrawal treatment to their detox center, but the patient lives 80 miles away, they have to have an arrangement where they can refer the patient to the program in their geographical area so the patient will have an opportunity to participate in treatment. So a relationship will need to be developed. It's no longer going to be acceptable that the detox people say, okay, you're finished detox, good luck, here's a card with a referral on it, go talk to the people out there 80 miles away. There will need to be a much greater effort to link patients across levels of care. Each treatment program has its own philosophy. I can't tell you how many places I've been in the last 30 years, even in the last 5 years, where people say, we don't use medicines, we don't believe in medicines. Well, that's like saying we don't believe in penicillin. Medicines aren't something you believe in or not believe in. Medicines are a tool, like counseling, like CBT, like motivational interviewing, that have evidence of efficacy, and they're needed to be used for some patients. That change is something that will have to happen if an organized system of care is going to be developed, and if substance use disorder services are going to be viewed by the rest of healthcare as a professional service. It's just not going to be acceptable to say we don't believe in this. The personnel and the program has been often in the past structured by people's personal philosophy, by their own personal experience. The priority is going to be within an organized system of care that people use evidence-based practices. We have things that we know work, and it's going to be expected that people will use those. There's been in some places the idea that people are cured from their substance use disorders, and so they complete treatment, they're given a nice firm handshake and sent out into the community, and that's it. That's the end of the responsibility for the treatment program. No longer. It will be important, even when someone is finished with an outpatient episode, that they be introduced to recovery support services and that they be expected to engage in some form of ongoing recovery support. And so the linkages will be critical. And we go from an acute treatment orientation to a chronic condition that's managed and monitored for some people over a lifetime. Now the knowledge, skills, and attitudes that will be needed, historically we have defined them in TAP 21, which is a SAMHSA document. It still has some very useful information, but right now it's out of date and it's incomplete for current needs. And so it really needs to be revised, and the things that were taught as being the required skills out of TAP 21 definitely need to be augmented and increased. Here's some of the basic stuff. Now this comes out of TAP 21. People working in specialty care are going to need to know about addiction. They're going to need to know the factors that go into addiction, the different models of addiction. They're going to need to know the behavioral, psychological, physical health, and social effects of drugs and alcohol. They're going to need to understand the interaction between substance use disorders and medical conditions and mental health conditions. They're going to need to understand where substance use disorders fit into the whole person's health care. They're going to need to know about evidence-based practices. They're going to need to practice evidence-based practices, including recovery skills, relapse prevention skills, development of continuing care skills. It's certainly going to be encouraged that people stay up on the newest science. If you're a physician and you're providing treatment for diabetes or heart disease or cancer, it's expected you read the journals and that you participate in ongoing continuing education to stay current on newest techniques, newest information, and that's going to be expected for substance use disorder professionals working in specialty care. That even within the substance use disorder system, an interdisciplinary team will now be involved. It's going to be important. Drug Medi-Cal provided services are done under the supervision of licensed physicians and psychologists and other licensed professionals, and that will need to be, so the counselors and others will need to work within a team. And of course, the services will need to be culturally and linguistically appropriate. ACM criteria will be important. Placing people in the proper level of care. It will no longer be acceptable that if a person walks into your treatment program and says, hi, I've got a drug and alcohol problem, that they automatically get admitted. They need to be assessed, but they may need a different level of care than you have available based on the assessment. You will need to have a program that you work with who has that level of care and be familiar with it and know how to get them to that program and facilitate that, as opposed to quickly admitting them in so you get the patient and somebody else doesn't get the patient. That's not going to be acceptable within an organized system of care. And be familiar with the clinically appropriate application of medication-assisted treatment. I did a survey about 5 years ago where I asked people working in what we called then drug-free treatment, residential and outpatient treatment, how many of them had ever referred a patient to methadone treatment, and consistently the answer was 0. Well, I suspect that some of the patients that you were seeing could have benefited from methadone treatment and were more appropriate for methadone treatment. And that kind of thing will be important. And vice versa, that when people walk into a methadone clinic, that may not be the most appropriate treatment for them, and it will be expected those patients will get assessed and referred to the proper level of care. But this issue of not believing in medications as part of the continuum of care is really an old concept, and if it's one you're holding on to, you really should consider a different career. Because this is not going to be an acceptable standard going forward. Okay, I've got a stall on my. May, are you there? And can you forward the slide?
Did you get
Thank you.
Okay, good.
Okay, thank you.
Maybe it was intentional so we could pause and talk about the NTP question that came up.
Okay.
So let me share that with you again. The question was, I'm an office manager for an MTP clinic and I'm aware NTP is included in the waiver. I would like to hear some info on how this will all work and affect us. Well, I think the biggest way it'll affect you is that you won't be working as a little island of NTP, where all you do is NTP, all you think about is NTP, and your only responsibility is how many milligrams of methadone do they get. You will now be need to be thinking about whether they can benefit, possibly. Maybe this is someone it's at the taper of their methadone treatment, for one example, and maybe they can benefit going into a residential treatment program and finishing their withdrawal from methadone and getting a solid foundation to their abstinence when they're finishing treatment. On the other hand, when someone walks in the door and they're a 19-year-old who is taking Vicodin, and they may qualify technically for methadone treatment, but when you do the level of assessment, they really would probably be more appropriate for outpatient care, possibly with buprenorphine or Vivitrol. If you're not providing that, then it will be important for you to have know of an organization where you can get that done, or you add those services yourself. It's simply that in terms of the actual delivery of methadone treatment for patients appropriate for methadone, your life won't change a lot. There may be some increased documentation issues, I suppose, but you're thinking about what does this person need in addition to or as an alternative to methadone is going to become more essential, that you think of the whole continuum of services, not just everybody that walks in the door goes into our treatment program. Okay, so a couple of last slides. We are talking, this concept of patient-centered care is something that you'll hear a lot more about
in upcoming years in healthcare in general and substance use care in particular. And it's something that when I first heard about it, I thought this is kind of a silly idea, but it's something that you would be good for you to become aware of. It really is about considering the patient in the discussion of what their treatment needs to be and what it needs to address and how it should be addressed, and getting their input within the treatment planning situation. Obviously, the ethics and behavioral standards of conduct are going to be important, increasingly important, and the idea that supervision is no longer going to be optional. It's going to be a requirement that there be some plan for clinical supervision for licensed practitioners to oversee and sign off and be meaningfully involved in what it is that the counselors are doing so that it's done under a licensed professional. So this will, and getting ongoing continuing education will be important. And could I get the next slide?
Click back on the, there.
Okay. Here are some of the evidence-based practices that will be increasingly used. Many of you are aware of these, but just to reiterate, addressing people's co-occurring disorders will be an expectation. Now, if you don't have a psychiatrist, it will be important for you to work together with a local mental health practitioner and someone who can help address those co-occurring disorders. Medication-assisted treatment goes without saying. Motivational interviewing should be one of the main skills that everybody uses every day, all the time. Cognitive behavioral therapy provides a set of skills and tools that are part of most behavioral treatment plans, recognizing the specific needs of female patients, behavioral treatments for stimulant use disorders, and dealing with patients with chronic pain. And these are all, this is not an exhaustive list. This is just some of the issues that will need, some of the evidence-based issues that will be needed. And next slide, please. Okay. So there will be shifts required in how people think about this, that there's a shift in the mindset that you're not operating as a standalone program, you're operating as part of an overall system of care, which, by the way, is something that it will be developing over the next course of the next months and years. It's not in place yet, so if you feel like nobody's told you what to do, that's true, but there will be active plans in all counties to develop these organized systems of care. And that these care systems and these philosophies for this organized system of care will be based on evidence-based approaches, not personal, personal experience foundations. And could I get the next slide? It'll be important for people to develop knowledge and skills in the use of the ACM criteria, and this will be an important training need. You'll hear there will be training. There's already been some trainings. There will be more on the ACM criteria. And I just want to mention that the ACM criteria are one area of training that will be important, but not the only area of training. Counties will set up utilization management procedures that will probably be new and something that people need to learn about, in addition to meaningful quality assurance processes to track the quality of the service given. There will need to be the creation of true community program linkages with other elements in the continuum of care, including methadone programs, and the development of more effective intra and inter-program communication to reduce the silos and the silo-ettes. And so there will really need to be, people will need to operate in a different way. Next slide, please. So how will the workforce learn these new knowledge, skills, and attitudes? Well, there'll need to be a training effort, and it's something that we're in the process of discussing what that would be and how it's going to be rolled out and how it will occur. But without a comprehensive program of training over the next 2 to 3 years to create these organized systems of care and educate the workforce and get the workforce's buy-in and their active participation, there'll need to be an extensive program of training and information and dialogue with programs and counties and between programs. And so we're extremely interested in the nature of the development of this overall program for the workforce. Next slide, please. Okay, in conclusion, the Affordable Care Act and the Drug Medi-Cal waiver will have a major impact on substance use service delivery in California. There will be two areas where new sets of skills will be developed, and it's certainly possible for one person to develop both sets of skills, but you'd find that in different settings you'd be likely to use very different skills, and it just would be important to match the skills and knowledge with the most appropriate setting. And next slide, please. In both systems, the substance use disorder workforce will need to shift toward providing evidence-based care. Care in both systems will be part of a larger system of care. You'd be working within primary care when you're doing integrated behavioral health for the most part, although actually there are some substance use disorder organizations that are adding primary care to their array of services. So there you'd have primary care being added to behavioral care, and that's another model that can occur. And we'll see within an organized system of care there will need to be some new workforce demands in specialty substance use disorder care. Next slide. Future substance use disorder workforce will need to appreciate they're part of a larger system and that they no longer provide services in isolation. And the current and future substance use workforce will need to be trained to develop the knowledge, skills, and attitude and understanding of their role in the future healthcare system. And we think this is a major priority. And I think that's it. Thank you very much.
Okay, so let's get to the questions. We have some time now that we can continue the discussion. So let's see. First, we have one on confidentiality implications and which EBP brief assessments do you recommend? Problem is that I'm reading these not necessarily connected to when they came up, but I don't know if you, I know you had a slide on EBP, but I don't know about brief assessments that you recommend.
Well, I think one of the brief assessment, if you're talking about in the screening tool area, we have some very short screeners that are there's 1 or 2 item screeners. One of the better sort of intermediate, it's a bit more than a screening and it's a bit less than a brief assessment, is the ASSIST, the ASSIST, which is a World Health Organization instrument that is gives you a very good picture of a person's substance use disorders and some of their high-risk behavior. That could be one that is part of what's used in a primary care setting as a starter. I don't think we have fully documented yet what the better brief assessments are, but it is an area that as we start to develop a toolkit for behavioral health, that will be a real priority. The ASSIST will be one of them, but there will probably need to be others. The issue on confidentiality is a gigantic issue because we have 42 CFR, which is still a major part of the substance use disorder system, that patient records are private and have to be signed by the patient before information can be released. It can't be part of a general medical record. There's lots of discussions about that going on in Washington about how that may change or what the modifications would be, but right now we're still operating within specialty care, where 42 CFR is a requirement in the primary care settings, there's some discussion about how much 42 CFR requires is relevant to screening and brief intervention, and that's a little bit beyond my current knowledge.
Okay, yeah, okay, and now we have another question. Have there been conversations with the 12-step community and their acceptance of medically assisted treatment so that referring is easier and accepted to the 12-step community?
Well, I'm aware of programs here in Los Angeles County where you can go and be on medication, and it's considered, the same as if you're taking a psychiatric medication or if you're taking penicillin. That it's part of the way you're getting sober, and but that has not been it's not universal, certainly. And the question is, how do you talk to the 12-step community as a thing? It's people. It's people who are in recovery. I mean, there's materials in the 12-step literature that you can get that certainly are supportive of taking medication, but that doesn't mean every person who is participating in 12-step programs accepts that fact. And it's a matter of, I think, to the extent there's an official policy by the 12-step, the national 12-step headquarters, the use of medications in recovery is considered a very acceptable form of recovery. But among individuals, it may not be. It's a challenge that we've had. This article I mentioned in Atlantic Magazine is a wonderful example of what I've seen for 40 years, which is people taking one position or the other. This Atlantic article, they're very critical of 12-step. They're very promoting of medicines. I think that is all absurd. I mean, some people need medicines. Some people need 12-step. Many people need both. Many people need medicines for a while, then 12-step. I mean, this idea that it's one or the other is just absurd. There's no other area of healthcare or psychology where we say there's only one way to do anything. And it's been a very, very fruitless argument for 40 years, and I'm hoping we'll start to see more acceptance of all things that are effective, including 12-step, certainly, rather than my way is the only way and the other ways are the wrong way. But it's a change that has to happen over time. Hopefully it will occur as people get sober using different methods and are able to share their experience to create more acceptance of all ways of getting sober from drugs and alcohol.
So we have a comment. This person says the transdisciplinary foundation and treatment knowledge is the foundation of addiction treatment with most treatment providers. As well, this is a required curriculum in schools that are associated with certification boards. The continuum of care within treatment providers is to ensure that all clients are accessing the services needed. Client-centered services, client-centered services. So certified addiction treatment counselors are well aware of all modalities of treatment and work well within the system.
Well, I think that is a nice statement, and I'm sure that's true in some cases. That has not been my experience with many cases. And the fact that it is in the curriculum, I think, is excellent. The fact that it is used by everyone is not true. There's still a tremendous amount of resistance to the use of many of the evidence-based practices, and that's unfortunate because it makes for poorer patient outcomes.
Okay, we have one that says, also part of medically assisted treatment or NTP, what is the criteria what is the criteria? I work in admissions and we have all continuum of care, but MAT NTP criteria I have seen all over the map. Any thoughts?
Well, the state of California has very set criteria for who is eligible for methadone treatments specifically. The eligibility for medicines like buprenorphine and naltrexone, Vivitrol, is based on a physician's diagnosis and part of their treatment plan. I think that as part of the ACM criteria in helping people with placements and thinking through what is the proper treatment for a specific patient will become in some of the ACM trainings. That's what it's about, is giving people skills in a systematic way of making a determination of what is the treatment the patient needs. But right now, there's already very clear DHCS. There's a set of criteria for methadone. The others are left more to both the ACM criteria and a physician's diagnosis.
Okay, and then we have, what are the skill levels in our licensure anticipated for the supervision of substance use disorders counselors? For example, is it LCSW or LMFT or other for alcohol and other drugs?
That's a great question, and I know LCSWs. I think MFTs were recently added as acceptable people for licensed certification. You should check on that. I know psychologists, physicians certainly are, and LCSWs are. I haven't tracked that issue that close, but I'm pretty sure licensed marriage and family therapists will be eligible as supervisors to supervise clinical teams. But you should check on that one to make sure.
Okay, we had another question about CFR 42, but this one was about what about consent and compliance?
Consent for releasing information is certainly required before any information about substance use disorder treatment can be provided to anybody. Time-limited consent that the person signs before their records can be released. That hasn't changed in any way from the last, I don't know how many years, but that's still the same, and so consent is required. I don't quite get the compliance.
Yeah, they didn't specify. But when I'm thinking maybe the question was very brief, but maybe they're asking about how do you handle consent in an integrated environment, and the way some clinics do it is they have a consent that includes. Some people have, I don't know how you've seen it, but some have that include the different areas, the different health issues, including SUD.
Yes, it can be built right into the admission information, and where there's it's built into the other consent areas that they have, but it's done differently in different places, and it also is still a big area of debate and discussion. So I don't know that it'd be a little presumptuous of me to give you the answer, because I don't know the answer, and I think different places are developing different procedures for it. I know in a lot of the big electronic health records, it's a concern. Many of the big electronic health records don't have the capacity to or have a built-in feature for 42 CFR consent, and so that has to be done on paper when everything else is done electronically. So there's a whole bunch of issues around it that are still being worked out.
And some locations are just doing it as their legal team let them know that that's the best way of dealing with it.
Right. Yeah. There's a lot of different opinions about it, and different places are doing it differently. And I think it'll be sorting out in the next several years. But right now, it's still a big area of debate and discussion.
Yeah. Okay. So I have another one. This is a great direction to go. However, until the Department of Healthcare Services changes what Medi-Cal will pay for, this cannot happen.
Yeah.
That's the whole point of the waiver, though, right?
Yeah. The waiver, I mean, the waiver that has been submitted to the federal government ads for a whole new array of services that would be paid for by Medi-Cal, and that's a good thing. But it doesn't, as the comment implies, it doesn't fix everything. There's going to be a lot of details in bringing those services online, figuring out exactly how the payment plan works, how people will be able to act, how programs will be able to bill for those services, exactly what the mechanisms are. We're going to be in a period of flux and change for the next 2 to 3 years as this gets implemented. And part of the reason for the webinar is just sort of a heads up that change is coming, and it's not going to be business as usual. And but the good news is the DHCS, under the governor's direction, expanded the number and amount and intensity and variety of services that is paid by Drug Medi-Cal, and that's by any measure a great development and will benefit our patients. Are there going to be some problems in implementing? Yes, for sure. For example, if you want to deliver these services in a primary care setting, they have to have a special Drug Medi-Cal license, which many of them aren't going to want to go through the hassle of getting. Is there a way it can be delivered under regular Medi-Cal? All those kinds of issues will be up for debate, discussion, modification, hopefully to make the system more of a system. But it's been a great first step to see the Drug Medi-Cal benefit greatly expanded, and California is one of the places that has done the biggest expansion of its Drug Medi-Cal or its Medi-Cal benefit. So it's to the credit of DHCS and the governor that has been made available for California residents.
There's someone, I think, who's wondering if you know what's going on at licensing, because they ask, when will state provide a license for AOD master level and not LCSW or MFT? I don't know. Do you know anything about that?
I don't know the answer to that. No, I don't know the answer to that. I know that there are discussions going on, and that this issue of workforce and the future licensing and all of those things are a topic that's in discussion in some of the committees, but I don't know the answer to that.
Someone's wondering, how can we mainstream these recommendations in healthcare systems in California where integration is taking place, like in Los Angeles County, where the mental health department, the public health, and other departments are being integrated or considered to be merged?
Well, I think that the substance use disorder providers need to be included in the discussions. It's something that I was working on today, in fact. I mean, all of this is just happening, and there are committees in every county, and I know in LA County there's a meeting that occurs with the head of health services, the head of mental health services, the head of Department of Public Health, who meet regularly to talk about how these things are going to happen. There's the concept of health homes and health neighborhoods that are going to be these comprehensive networks of care, and substance use disorders services will need to be included in those, and to a greater or lesser degree they are being included, but it is a process that people need to be engaged in and finding out in their county how this is being done, and insist and encourage that substance use disorders be part of the conversation, that behavioral health integration does not mean mental health integration. It means mental health and substance use disorder services integration, and that I think is going to be an important, we're in an important period right now, because those decisions or those plans are being drawn up, and I think it'll be critical for substance use services to be championed within those discussions to make sure that for a change, behavioral health also includes substance use disorder services.
So there's a comment here, I think that's also about how primary care understands substance use treatment. The comment is, primary care has contributed to the addiction epidemic in the U.S. by overprescribing addictive medication. Will this be addressed within primary care?
Certainly some doctors within primary care have overprescribed medication, and we are aware of some parts of California where it's being done at gigantic levels. And when you go and you talk to the doctors and nurses in those settings, you hear a very compelling story about, we need your help, that they're not sure how to address these patients coming in demanding opiates, saying they have pain problems, some of them with legitimate pain problems, many would not, and ending up with people being given, lots of Vicodin and Oxycontin and other opiates being shoveled out in too much and contributing to the problem. But if you talk to the medical people, that's not what they want to do, but they're not sure what to do. And that since they've never been connected to addiction knowledge and services and personnel, they do what they have to do to get through the day. I mean, they have, they're supposed to see 5 or 6 patients an hour. They have to go quickly. The patient's demanding that they have pain. They write the prescription. They need to have some help so that they can have someone else address those patients in a way that is more congruent with understanding addiction, understanding recovery, understanding how to screen and how to use motivational interviewing to move people in a different direction. And I think my experience has been, limited as it is in primary care, that they are very aware of the fact that what they're doing is not the best approach to this, but they don't have the expertise to deal with it. Just a quick comment. I mean, one of the things, as in the little bit of time I've gone into primary care and been involved, I'm amazed at how much work those people have to do in such short time with tremendous patient demands, very sick patients, having to know about 1 million diseases. And, our little area of addiction is certainly an important area, and they acknowledge it as important, but they really are asked to do an awful lot for an awful lot of people in a very short amount of time. So I think most of them, I mean, there's some bad apples. There's some doctors that just are trying to run up a bunch of money by giving out opiates, but that's the exception, not the rule. I think in most cases the doctors are trying to get through their day and see all the patients they have to see, and they just don't have the knowledge and skills, and they're the ones who are welcoming with open arms the bringing behavioral health people with substance use disorder expertise into their systems.
I've got 2 related to education. One is starting with the doctor's side, which I think might follow from what you were just saying a little bit. Will medical schools add KSAs on SUD to their curriculum practice, so some specialization on SUD is built within the medical field, as it does now with diabetes prevention and treatment?
Excellent question. And yes, there's all kinds of activities. Tom McClellan and Hazelden have put together a 12-lecture session that medical schools can just buy, that they can bring in if they don't have the expertise. And something like 200 medical schools have purchased it and are using it. In all medical schools, there's pressure from SAMHSA and other HRSA to have them improve the education. What happens when you get in those discussions, though, with medical school curricula people is they give you the list of all the specialty care groups, dermatology, orthopedics, obstetrics, who all have way more stuff they want in the curriculum, too. So it's not as if the substance use material has been excluded because people don't think it's important. It's that there's a lot of what medical schools need to know that's important. But clearly there's a much greater priority being given in medical school curriculum to knowledge and skills about substance use disorders. So yeah, the answer is yes.
Okay, and then another education one was, will there be new educational requirements for SUD counselors? Currently, counselors need a certification. Will they now need a degree in behavioral health or a related field?
It's up in the air. I mean, it's up for debate. It's been in California debate for 20 years. The debate continues. I can't answer it because I'm not sure exactly how those decisions are going to get made or what legislation will be introduced. So it's not clear to me. But I suspect, regardless of what the requirements are, clearly the new systems, both behavioral health and specialty care, are going to need people to have some new education. So whether it's, you know, required as part of a licensing event or just because it's the right thing to do, it will mean the workforce needs to get a new set of skills, an added set.
A comment that follows from that is MFTs know nothing of addiction treatment, so that just kind of adds to that need for more people to get a broader training, more in SUD. Yeah,
I agree. I agree 100%. And I think you'd say the same thing about LCSW and clinical psychology training. There have been some advancements made in the last decade, but very slow and very minimal.
Okay, we still have a few more, so I'm trying to get through them. Let's see, we have one about certification. DHCS has not been efficient or successful in completing the recertification process. It's taken almost 2 years, and the majority are still in progress. There's a major concern to providers, counties, and no one talks about it openly. How in the world do we expect them to lead in practical terms a change as large as this whole organized system of care change?
Yeah, that's a very good question, and I think that, as I understand it, the development of the organized system of care will really be the county's job. That the part of the new Medi-Cal waiver would mean that the county will have to submit a plan to the state to talk about how they've created an organized system of care. So I suspect if you're a provider, I think starting in July, if the waiver is approved and the waiver gets through the way it's currently thought that it will, the state will be asking the counties to develop county plans for an organized system of care. And I would suspect, I would hope that all the counties, each county would bring together some expertise in the area of substance use disorders, would bring together the providers, would talk about how to create an organized system of care, and that would be done at the county level so that it's not going to come down as a master plan for every county from the state. But I do understand the recertification thing has been very, very frustrating, and if I was still a provider, I would be frustrated as well.
So it's 11:30. I have, I think, 4 more questions.
It's up to you. I mean, I can certainly do 4 more questions.
We can continue on a little, maybe like a few more minutes for those who want to continue and cover these questions, and we'll try to do them as efficiently as possible. One was just asking about, have you seen how other counties have done this and have integrated systems? So is there some hope in how some...
I think that on this webinar, or maybe it's the one that UCLA runs called the, we have one here, but Santa Clara County is doing a webinar on their organized system of care that they have. It's the Learning Collaborative that we have here at UCLA. It's a webinar series. And I believe somebody from Santa Clara County is doing a presentation on their county and how they develop an organized system of care. And I do think they've done some very good work in this area and have been real leaders in putting together a system of care.
Okay, great. And then we have one on residential programs are not in line to receive room and board compensation, even though we are going to be considered part of the continuum of care specialty setting. It's going to be a great disincentive to inclusion. Can you comment on any discussions ongoing regarding this? So do you know anything that's going on about this?
Only sort of tangentially. It was my impression that there's still the hope that the block grant funding, which will still, as of now, still coming from Washington to the state, will be able to be used for some of those kinds of costs that are not billable to Medi-Cal, but I don't know the details.
Okay, and then I think we're down to the last two questions. Oh. And there was a clarification one. I had read it as counties, and they had asked of countries if you have experience with how other countries have done integrated systems.
Oh, other countries? Yeah, we're doing quite a lot of that kind of work, and it's different. I mean, there are countries that actually have pretty well integrated systems of care. Most of them, you know, the European countries have done the most. The Dutch, the Swiss, they do have all levels of care and lots of different available options. And one of the measures is, of the people addicted to drugs in your country, how many of them are engaged in some form of service for their substance use? In the United States, it's about 10 to 15%. In Switzerland, it's over 60%. That is, so there are countries that have really looked at how to broaden the availability of services by adding lots of different kinds of services. Canada has, in some areas, a pretty good integrated care system, but I think everybody's still struggling with this right now.
Okay, we have the last two questions. I don't think we can, if there are any more questions that come in after this, we can send them to you maybe, and you can follow up with them, but I think we're at the end here. So one is, can a certified co-occurring specialist be able to do service with, be able to provide services with mental health?
I don't know the answer to that.
And then the last one is, let's see if I can get it. Will a required training of addiction be part of this process?
I don't know. I mean, I think that would be both a DHCS call as well as a county call. Counties may say, yes, they want all their people trained in XYZ, or the state may say, I think what's happening right now is this waiver is going in, and they want to get it approved, and once it gets approved, then they're going to need to figure what the next steps are, and that will occur, you know, through June of 2016. So this is an evolving, developing process, and that question probably has not yet been answered, and I don't know what the answer is likely to be.
And we should be hearing about the waiver being approved in the next week or two, I understand.
That's my understanding, yes. And that'll be a big sort of, you know, green light for some of this stuff to start happening, and then the counties will be going to work. Counties are already doing work, and then getting things put together into an organized system of care with all the pieces and requirements will be occurring July 15 through July 16. And so there's still a good ramp-up period for all this.
Well, thank you, Dr. Rawson. There's been some additional comments where people have said, great presentation, and thank you. So I just want to echo those presentations and thank our audience for participating. We have sent the PowerPoint out to those who were registered, and I think we will send it again, or we've been sending to people who have been asking us questions. Maybe there's some people who, for some reason, we didn't have their email and didn't get to them. So I'm going to give you the last word, Dr. Rawson, but I just want to take care of some things. There will be an evaluation that will be sent to you immediately once we end. You will be getting that, and we appreciate you completing it. And we look at it, and it helps inform the work that we do. So we appreciate that. And again, I want to thank you, Dr. Rawson, for your time today and for this very helpful presentation on this issue of workforce in an integrated environment in a comprehensive system of care.
Well, thank you for inviting me. And in my 40 years of working in this area, this period coming up is going to be one of the most interesting, exciting, and I think positive periods of change for people who are working in the workforce for substance use disorders, and I think it's a great field to get into. Hopefully we can bring some new people, some younger people in to get engaged in this, because it's a bigger job than what we currently have the workforce to handle. And thanks to all of you for working in this field and working with this population and helping the people in California with substance use disorders. So thank you very much.
Okay, thank you everyone. That's it. That concludes our webinar for today.